Our lecture today, neonatal hyperbilirubinemia, or we can say neonatal jaundice. Neonatal jaundice is so important subject that should be kept in mind regarding any newborn. So, neonatal jaundice is a condition characterized by excessive concentration of the bilirubin in the blood. As you know, bilirubin that produced from reduction of the RBCs. Bilirubin, net result of the RBC destruction. Simply after reduction of RBC, and why this happened, of course, for a few causes that we can mention later. So bilirubin, the net result of the RBC reduction, first by enzyme that called heme oxygenase that convert heme to the biliverdin, and then by biliverdin reductase enzyme, biliverdin converted to the bilirubin, and bilirubin should be connected to the protein, and then this type of bilirubin, of course, indirect bilirubin that should be converted to the direct bilirubin by presence of glucuronidase transferase enzyme in the liver. So indirect bilirubin should be converted to the direct or conjugated bilirubin to be excreted easily without any hazard. This is simply the pathway of bilirubin production. We have two types of neonatal jaundice, unconjugated and conjugated. Unconjugated or indirect, as we say, that result immediately from destruction of the RBC according to the enzyme that we mentioned. So unconjugated, mostly physiological in an acceptable level, or sometimes pathological in origin. Conjugated or direct bilirubin, of course, all the time pathological in nature. Of course, conjugated or unconjugated type of bilirubin leading to the jaundice that may result in severe sequelae like neurotoxic to the growing brain of the newborn and causing what we call kernicterus. This is the most serious complication, of course, of the bilirubin. Normally, bilirubin, as we said, is a bile pigment formed from the destruction of the heme that is mainly comes from the destruction of RBCs. So the net result of the RBC destruction is bilirubin. As we mentioned, the most common cause of the bilirubin or jaundice among newborns is physiological. Of course, physiological, to be in real definition, should be excluded from the other serious problem or cause of the RBC, hemolysis, or other metabolic problems. Physiological jaundice to be identified in proper way should be characterized by the following. Jaundice should appear after the first day. Definitely, jaundice that appear in the first day is pathological. The increment in the level of the bilirubin not exceed 5 milligram per cc per day. Daily increment in the bilirubin level should not be exceed 5 milligram per cc per day. While the total serum bilirubin concentration should not exceed 13 milligram per deciliter in term, and of course 15 milligram per deciliter in a preterm. Of course, physiological jaundice should be indirect bilirubin. Indirect bilirubin. Direct never to be physiological. Direct never to be physiological. Physiological jaundice should disappear after the first week of life. And the most important criteria for physiological jaundice, the well-being of the newborn is good. All the time should be good. Good feeding and good activity. So these are the criteria of the physiological jaundice. Should not be appear the first day. Daily increment not more than 5. And total increment not exceed 13 for mature, and maybe more for a premature because of immaturity of the liver enzyme. This is a criteria should be kept in mind. This should be differentiated from the pathological. Pathological jaundice, of course, deviation from the previous criteria that we mentioned, considered pathological. Physiological jaundice, important, maybe out of the limit that can be mentioned as exaggerated physiological jaundice. The exaggerated physiological jaundice and the other causes of course pathological great risk associated with indirect hyperbilirubinemia that causing a severe brain damage. So our job in this aspect to prevent a high elevation of the bilirubin level, and then we prevent the more serious sequelae kernicterus. Of course, the development of the kernicterus depends on level of the indirect bilirubin, duration of exposure to the bilirubin elevation, the cause of jaundice, and the infant well-being. These factors play an important role to prevent the more serious net result of the bilirubin, and that is the kernicterus. Keep in mind, direct bilirubin not causing kernicterus, mostly. Here, in brief, we can mention some important non-physiological indirect jaundice, the most common and most serious hemolytic disease of the newborn, like RH incompatibility, ABO incompatibility, immune or non-immune like spherocytosis, hemoglobinopathies like G6PD, or alpha thalassemia. So hemolytic may be immune, like RH or IBO, or non-immune, like spherocytosis, hemoglobinopathy, or red cell enzyme deficiency. This is important to differentiate between hemolytic and non-hemolytic. Other important cause, extravasation or extravascular blood collection, like kidney hematoma, increase interior hepatic circulation due to the intestinal obstruction. This possibility so important, as we mentioned in the beginning of the lecture, in the bilirubin pathway, we can repeat again in a brief. RBC disrupted by heme oxygenase this heme oxygenase convert heme to the biliverdin, and by presence of the biliverdin reductase, bilirubin reductase convert biliverdin to the bilirubin that should be connected to the protein in the liver. After that, hepatocyte, and by presence of glucuronidase enzyme, convert the indirect bilirubin to the direct bilirubin to be excreted in the bile and then through the intestine or urine. In case of intestinal obstruction, we have another enzyme in the intestine that's called glucuronidase enzyme. In case of intestinal obstruction, this level of enzyme increased. This enzyme converts the direct bilirubin again to the indirect. And if this process happens, the indirect again should be returned to the liver to be converted again to the direct. That's called enterohepatic circulation. Enterohepatic circulation from the intestine to the liver again. And this is add more burden to the liver beside the already present destructed RBCs. This is called enterohepatic circulation. Breastfeeding associated with poor intake, important cause. Disorder of the bilirubin, tells like Gilbert syndrome and Krieger-Najjar, of course, to the level of transferase enzyme. Metabolic disorder like hypothyroidism. Hypothyroidism important for indirect bilirubin due to the lazy liver enzyme. As you know, hypothyroidism means lazy metabolism, and then lazy liver enzyme, then lazy liver enzyme delay and prevent conversion of the transferase enzyme to be active, and then accumulation of indirect bilirubin. Here, important issue that should be differentiated from each other that we call breastfeeding jaundice or breast milk jaundice. These different issues, keep in mind different issue, breastfeeding jaundice and breast milk jaundice. Breast milk jaundice. Breast milk jaundice may result in a high level of the bilirubin, of course, due to the presence of the enzyme that we call glucuronidase enzyme, similar to that present in the intestinal that we talk about in a brief area in this lecture. So, breast milk jaundice due to the enzyme that help in increment in the indirect level. Breastfeeding jaundice, of course, area in appearance due to less increase or less intake of milk that result in dehydration. So breastfeeding jaundice due to the dehydration or less energy that appear earlier in the first few days, while breast milk jaundice appear after the first week. So keep in mind the simple difference between the breast milk jaundice due to the enzyme and that appear after the first week, and between the breastfeeding jaundice that result from less intake or due to dehydration that appear in the first week. Few lines about Crigler-Najjar syndrome. It's a serious rare autosomal recessive. Here we have a permanent deficiency of glucuronidase enzyme. We mention this enzyme and we say this is an important enzyme that converts the indirect bilirubin in the liver to the direct one to be easily excreted and prevent the most serious sequelae of the jaundice and kernicterus. So glucuronidase enzyme very important in conversion of indirect to the direct jaundice. We have two types of Crigler-Najjar. Type 1, the most severe one, and complete absence of the enzyme. And we have type 2 with little glucuronidase enzyme. Here in type 2, we can add enzyme inducer like phenobarbital to increase the level of glucuronidase enzyme and reducing of the indirect bilirubin. While type 1, of course, not respond to the phenobarbital because there is no already present of enzyme. So type 1 should be kept in mind and should be treated aggressively to prevent kernicterus. Keep in mind this possibility. If we have a high level of the bilirubin, a high level of the indirect bilirubin in absence of hemolysis, here we think about Crigler-Najjar syndrome. As you know, a high level of the bilirubin generally indicate hemolysis of the RBCs. While if we face a case of a high level of the indirect bilirubin in absence of hemolysis, we should think about Crigler-Najjar because the glucuronidase enzyme here not present. Keep in mind, important possibility. So hemolysis with level of bilirubin, of course, important relation to be explained. Other problem, Gilbert disease, caused by mutation of the promoter region of the glucuronidase enzyme and result in mild indirect jaundice and usually occur after puberty and not need treatment. Of course, this is simple type that may appear after simple illness or fever. Of course, notes and notes and simple in comparison to the Crigler-Najjar. If someone asks you about the causes of the jaundice in the first week, your answer should be as follows. Of course, physiological jaundice first, ABO incompatibility, hemorrhage, sepsis, breastfeeding jaundice, not breast milk jaundice. Keep in mind, breastfeeding jaundice cause first week jaundice, while breast milk jaundice cause jaundice later. Crigler-Najjar, urinary tract infection, polycythemia. While other important causes of jaundice after the first week, breast milk jaundice, septicemia, bile duct atresia, hepatitis, galactosemia, hypothyroidism, cystic fibrosis, inborn error of metabolism. This is important question. All the time we can ask. As we say, most serious net result of the complication of bilirubin is kernicterus. What we mean by kernicterus? is a severe neurological condition with a very high level of unconjugated bilirubin in the blood. Not conjugated, keep in mind, unconjugated bilirubin in the blood. Kernicterus is characterized by yellow staining of the basal ganglia and hippocampus, which is accompanied by widespread cerebral dysfunction. As you know, the new brain of the newborn is so sensitive to any insult. So this insult results in severe, immediate, or remote complications. Why we talk about this structure, about bilirubin or jaundice? Jaundice can be a highly prevented disease, If neglected, of course, result in severe complication. You may face a crippled new human being. Cause of kernicterus. Kernicterus occur when free bilirubin cross the blood-brain barrier and enter the brain cell. So free bilirubin, of course, indirect. Normally, unconjugated bilirubin is bound tightly to the albumin, which prevents bilirubin from crossing the blood-brain barrier. Free bilirubin exists when this amount of the unconjugated bilirubin exceeds the binding capacity of the albumin in the liver. As we say in the simple explanation of the bilirubin metabolism, bilirubin first should be converted in the liver by presence of transferase enzyme and should be bound to the albumin, to the protein. Each molecule of the albumin has its receptor for a certain amount of the bilirubin. If the capacity of the albumin receptor exceeded and we have a lot of free bilirubin, this free bilirubin, of course, can pass to other important organs, including the brain, and result in severe brain damage. So albumin, important part in excretion of the bilirubin. So kernicterus can happen in a lower concentration due to other problems, as we mentioned, displacement from the albumin binding site in certain conditions. For example, sulfa drugs that given to the newborn, of course, immediately attach the receptor on the bilirubin, sorry, to the albumin. If these drugs attack the receptor on the albumin, here we have extra amount of the bilirubin that may be free because the receptor of albumin occupied by other substances like drugs, as we mentioned, sulfa. So we have a high level of the free bilirubin. Here we expose the brain for more albumin in a less level of bilirubin. Of course, many conditions help in the attachment of the bilirubin to the albumin site, like asphyxia, acidosis, or hyperosmolar solution. So keep in mind, these conditions may cause kernicterus in low level of the bilirubin. Why? Because the receptor on the albumin occupied by certain substance. To be continued with the kernicterus causing, of course, a lot of neurological symptoms. The ileus clinical manifestation may present as lethargy, hypotonia, irritability, poor moral response, and poor feeding. This is, of course, ileal sign symptom in the presence of high level of the bilirubin. If you don't interfere, we have a late sign like bulging fontanelle, obstetonus bochonic, pulmonary hemorrhage, fever, and seizure. Seizure, it means your patient receive a critical zone. Infant with severe case of kernicterus die in the neonatal period. Survived infant may develop nerve deafness, chorioathetoid cerebral palsy, mental retardation, and discoloration of the teeth. As you see, we have a severe and aggressive sequelae if kernicterus not treated immediately. So kernicterus can be prevented by avoiding a high indirect level and avoiding condition and drugs that may displace bilirubin from the albumin. Ileus sign occasionally may be reversed by immediate external transfusion. So the ileal symptoms may be prevented or may be reversed, while late sign, if we have accumulation of the high level of bilirubin inside the brain cell, at that time, of course, all the event not reversible. So the early identification of the condition and early intervention can help to prevent a such serious condition. Treatment of this important condition. Why we can say it's important? Because can be prevented easily if you deal correctly with the causes of the bilirubin. So here, whatever the cause, we can prevent the high level of bilirubin. We start with phototherapy. It's effective and safe method for reducing indirect bilirubin, but it was initiated before serum bilirubin increased to level that is with kernicterus. Simple and effective. In-term infant phototherapy is begun with the indirect level between 16 and 18 milligram per deciliter. In a premature infant, when bilirubin is at a lower level, should be start with phototherapy. Blue and white light are effective in reducing bilirubin level, both blue and white. Of course, both of them. Of course, medical with special wavelength. Usual light at home, of course, not effective. To be continued with the phototherapy, what are the mechanisms of phototherapy in reducing the level of bilirubin? So it's a photochemical reaction producing the reversible, more water-soluble isomer of the indirect bilirubin. This isomer can be excreted by passing the liver conjugation system or excreted in the urine. As we say, the liver job to convert the indirect bilirubin to direct to be excreted easily out. The role of phototherapy not convert the indirect to the direct. No, just to make a more water-soluble isomer of the indirect bilirubin. So change the isomerity of the bilirubin to the safe one. Phototherapy need time. need at least 6 to 12 hours to have a measurable effect and must be started at the bilirubin level below those indicated for exchange transfusion. The therapeutic effect of phototherapy depends on light energy and effective wavelength. So this wavelength, of course, so important for conversion of this reaction for safe isomer. So the ordinary light containing a different wavelength not effective. The distance between the light and the infant in the incubator should be within 15 to 20 cm. The surface area of exposed skin should be changed all the time. Then the newborn, of course, and we have a different phototherapy. We have a simple phototherapy and we have an extensive phototherapy. Of course, extensive phototherapy give a light exposure to the whole body from all the areas from below and above. Complication of phototherapy, so simple complication, increase in susceptible water loss and dehydration that should be avoided by increment of the feeding, micropapillary skin rash, lethargic masking of the cyanosis, nasal obstruction by iPad, and potential retinal damage. Of course, every newborn in the phototherapy should be covering both eyes. Restitute, no diarrhea, bronze baby syndrome infant with direct jaundice. Keep in mind the last point related to the direct jaundice. Direct jaundice should not be treated by phototherapy. Direct jaundice not treated by phototherapy. If called the bronze baby syndrome. Again, phototherapy not help in direct jaundice. Other option is treatment of the jaundice that we intravenous immunoglobulin used in immune type of hemolysis, like in RH or ABO incompatibility. Of course, started with low level of bilirubin and not effective in high level. So can be used in immune type of hemolytic jaundice. Metalloporphyrins used as a single IM dose on the first day of life may reduce the need for subsequent phototherapy. The proposed mechanism is competitive enzymatic inhibition of the rate-limiting conversion of the heme protein to the biliverdin, heme oxygenase enzyme that we mentioned earlier in the lecture. And we say the heme oxygenase, important enzyme that help to convert heme to the biliverdin. So if we antagonize this enzyme, we didn't have extra protein that converted to the biliverdin and so on to the bilirubin. So heme oxygenase antagonized by metalloporphyrin and prevent the next metabolism of the bilirubin. Exchange transfusion, the most important in a high level, of course, of bilirubin. Exchange should be principal in hemolytic disease or when the bilirubin concentration is very high. This procedure directly, keep in mind this. So the role of the exchange to remove the bilirubin from the intravascular space. As we say, high bilirubin level may pass to the brain. So exchange, remove the high level of bilirubin. Then remove unbound antibodies that initiate the hemolytic process. As we say, antibodies that can cause extra RBC hemolysis can be removed by exchange, and in exchange remove the affected red blood cells, and besides correction of the anemia. Keep this important effect of exchange transfusion. Exchange transfusion usually is performed when the serum bilirubin concentration 20 milligram per deciliter or more. This is a very important level in practice. The specific bilirubin concentration that require treatment varies with gestational age, the cause of jaundice, and the presence of other medical complications. So complicated newborn may need exchange in the lower level in comparison to the full-term infant. As we say, we can find cases of cornicterus in a low level of bilirubin if the newborn complains from medical problems. Here we have different level of bilirubin that may need exchange. As we say, 20 milligram per deciliter. Keep in mind, and this is the important level that may need exchange transfusion. A symptomatic infant with physiological or breast milk jaundice may not require exchange unless it exceeds 25 milligram per deciliter. Here, you should make a balance between the general condition of your patient and the level of the bilirubin. But generally, we can follow the level of the rule of thumb. All the time, we can take the percentage of 10% of the birth weight in grams. As an example, when I have a newborn with 1 kg in weight, here the level of exchange should be at level of 10 milligram per deciliter. While if I have a newborn with a weight about 1,500 grams, the level of exchange should be at 15 milligram per deciliter. So this consider a 10% of the birth weight. 10% of the birth weight. 1 kg of birth weight, the level of sin may be at 10 milligram per deciliter of bilirubin, while 1.5 kg, as mentioned in the example, can be exchanged at the level of 15 milligram per deciliter, and so on. Newborn with 2 kg can be exchanged at a level of 20 milligram per deciliter. This is follow the rule of thumb that we call 10% of the birth weight. Here we can explain certain facts about the procedure of the exchange transfusion. Usually performed through the umbilical catheter in vein to the distance near about 7 cm in full term. Keep in mind, the umbilical catheter should be inserted in the vein, not in the arteries. As we mentioned, we have one vein that connects to the portal system, then to the right side of the heart, and we have 2 arteries that comes from the internal iliac. The distance of introduction of the catheter not more than 7 cm. exchange time not exceed 1 hour. In every exchange, we can aspirate 20 ml of infant blood alternated with an infusion of 20 ml of the donor blood. So when we insert the catheter inside the vein, we aspirate 20 ml from the infant and discard. Then we infuse 20 ml of donor blood. Of course, 20 ml of infant that transfused may be differ according to the well-being of my patient and according to the weight and according to the maturity. We can exchange 10 ml according to the weight, and we can exchange 5 ml according to the weight or maturity of my patient. So I take 5 ml of blood of infant, and then I give a 5 ml of donor blood. Or I take 10 ml, and then I give 10 ml of donor blood. That we call it exchange. We can take and give. What's the type of the blood that should be used? Important. In RH hemolytic disease, what's the type of blood that can be used? Of course, before delivery, we can prepare O negative blood. O negative blood. Before delivery, we can prepare O negative blood for exchange transfusion. After, of course, this type of blood can be matched with the mother, After birth, we can use RBC of the fetus in the RH of the mother. So can exchange blood according to the RBC of the fetus or the newborn in RH of the mother. So in both before and after birth, you can use the same RH negative. Keep in mind, before birth, we can prepare O negative blood for exchange and cross-match with the mother. After labor and we receive the newborn, we can use blood of the same RBC of the newborn with RH of the mother. Here we can cross with both mother or even with infant. Keep in mind, before delivery, we prepare O negative, and after delivery, of course, we prepare blood that are compatible with the newborn by the same RH of the mother, both RH negative. In case of AB1 compatibility, use RH specific RBCs. Here we have different type of RH. So we can use the RH of the baby by the blood group of the mother. The opposite is true in comparison with the RH negative mother. We can use O blood group with RH of the baby, Well, in RH negative, we can all the time use the RH of the mother. Keep in mind. The amount of the blood that should be exchanged, of course, according to the question, term or preterm, we can use 85 ml per kg multiplied by 2 by weight of the baby. Why we use 85 ml? Because the newborn containing about 85 ml of blood per kg. By 2, we can make exchange twice, multiplied by weight. So this equation important for estimation of the blood that be needed for exchange. Important, the infant stomach should be emptied before the transfusion to prevent aspiration, and the temperature should be maintained and vital sign, of course, monitor. After exchange transfusion, the bilirubin level must be determined at frequent interval every 4 to 8 hours. Why? Because bilirubin may be a rebound within hours after exchange. This rebound or new increment due to the result of continued hemolysis and redistribution of the bilirubin from the other tissue. As you know, in bilirubin, we didn't prevent the whole hemolysis. Yes, we remove the affected RBCs and we remove a lot of antibodies, but the hemolysis may be continue in the presence of a high level of bilirubin, high level of the antibodies, or a high level of the affected RBCs. So continued hemolysis or redistribution of the bilirubin from the other tissue may make the bilirubin to be rise after exchange, and the newborn may need another exchange if the level return to be high. Any question, please?
العفو دكتور، تقدر توضح مال الاي بي او incompatibility بس ما يخص الاكسشينج؟
Yes. Your question regarding the type of the blood?
Yes, about the type of blood.
Yes, I read it. We can use ORH specific RBCs or blood group O of the mother with RH specific RBC. These RBCs contain low level of antibodies and lack antigens that could trigger any circulating maternal antibodies in a newborn. Simply, we can use the blood of the mother with RH of the baby. If the mother O positive, of course, as from the name ABO, we can use RH of the baby. For example, the mother O and the baby A, we can use O positive RH, O positive RH. We'll take the blood group O by the RH of the baby, by the RH of the baby. Clear? Blood group O by RH of the baby, not as that in the RH incompatibility. Okay? Of course, exchange transfusion not free from complications. We have acute complication like transient bradycardia, cyanosis, transient vasospasm, thrombosis, apnea, necrotizing enterocolitis, visual perforation or hemorrhage, metabolic encephalopathy. This is acute. We have a late complication, late anemia, gas versus host disease reaction, specific bile syndrome, and portal vein thrombosis. Here we can comment on the late anemia. As we say, in exchange transfusion, we take blood and then we give the same amount. To avoid late anemia, we can add extra or give extra 20 ml of blood without exchange. We can add 20 ml of blood without taking off 20 ml of blood from the newborn. Of course, at the last aspiration of the procedure, just we give. This is, of course, to prevent anemia. And the most important for you in the practice to avoid a late anemia, to make a continuous mixing of the blood all the procedure. All the time during the procedure, we can make a mixing of the blood to prevent stagnation or precipitation of the RBC and the late amount of high level of the plasma. So if we didn't mix the blood, we have late anemia. Why? Because the last amount of blood may be contain a lot of plasma in comparison to the RBCs. Here we can talk briefly about direct bilirubin. Direct bilirubin level, of course, when the 20% of the total bilirubin is direct. When the 20% of the bilirubin is direct, it means I deal with the case of direct bilirubinemia. So if I have a 10 milligram deciliter of bilirubin, and I sent for fractionation of the bilirubin for direct or indirect. If the indirect was 8 and direct was 2 milligram per deciliter, this is definitely a case of direct bilirubinemia, direct hyperbilirubinemia. So I take a less level of the bilirubin in comparison to the high level of the indirect. So the example in front of you, 2 milligram per deciliter or more than 20% of the total bilirubin is direct. This is considered direct hyperbilirubinemia. Direct hyperbilirubinemia never to be physiological. Direct hyperbilirubinemia is not neurotoxic to the infant, but signifies serious underlying disorder involving the cases of hepatocellular injury. So better for me to deal with indirect hyperbilirubinemia in comparison to the direct hyperbilirubinemia. Direct bilirubin all the time is pathological and may be result from the serious problem, in spite of it is not causing a neurotoxic effect. Cause of direct jaundice: torch infection, metabolic disorder like galactosemia, bacterial sepsis, obstructive jaundice, prolonged administration of the intravenous protein, neonatal hepatitis, alpha-1 antitrypsin deficiency, cystic fibrosis, inspissated bowel from the prolonged hemolysis. So this is important causes of the direct bilirubin. Diagnosis of jaundice that mainly direct depend on conjugated fraction of the bilirubin level, liver enzyme, bacterial and viral culture, metabolic screen, ultrasound, sweat test, possible liver biopsy. Treatment of such a problem, of course, directly directed to the jaundice of the newborn, and of course searching for a cause in a simple workup that we mentioned here. All the time you should send for direct and indirect bilirubin to know by which type that I deal with regarding the type of the bilirubin. Any question, please? Any question, please?
إن شاء الله ماكو دكتور.
إن شاء الله.